Columbus. I'm Councilmember Remy, Chair of the Public Safety Committee. I want to thank Council President Hardin for attending today, as well for being my co-host for today's hearing, and also to thank the Mayor Andrew Ginther, for being here for this important discussion as well. A reminder, this hearing is currently live on YouTube and Facebook, and is also live and being recorded for rebroadcast on CTV, Columbus's government television channel 3. The rebroadcast schedule is available at www.columbus.gov. As the chair of Public Safety Committee for the Columbus City Council, my number one priority is the public safety and well-being of our residents. Public safety is not a privilege, it is a right. All year, you have heard announcements of incredible programs, funding opportunities, press conferences about new initiatives and operations, and witnessed various community events like Public Safety Week in June, all related to increasing public safety in our community and in all neighborhoods of our community, because everyone deserves to feel safe in Columbus, Ohio. When we think about what helps increase public safety, we have to consider all the tools in the toolbox. Alternative crisis response programs, like the ones that we will hear more about tonight, are critical to our overall safety system and programs. These pilot programs, in my opinion, deserve to be shared widely, as well as to be expanded into full programs in coordination with our external partners. The longevity of alternative crisis response is part of why we are convening here tonight, and I look forward to hearing from all of our presenters, guest speakers, and public speakers. Council President, I'd like to turn it over to you for your opening remarks.
Sure. Thank you so much, Chair Remy, and I also join with you and welcome the Mayor back to Council Chambers. It's changed a little bit since you might have been here last, as we prepare to welcome in 2 additional council members this coming January. But I want to thank everyone for being here. And we often say that this chamber is the people's living room. It's a place where we gather to have important conversations, and there is truly no more important conversation than how we keep each other safe. I also want to provide some context for today's hearing, and it's important that we realize that today is not the start of a new idea, but it's a continuation of a conversation that we've been having over several years about how we reimagine what safety means for all of us in our community. Historically, police have been the first responders to every societal problem, from mental illnesses to substance abuse to homelessness to noise complaints to traffic speeding. You dial 911, and no matter what the issue is, you'll see a cruiser in your driveway with flashing lights. We know that's not how it has to be. We've seen all too often how someone in crisis can end up in a confrontation that leads to difficult outcomes, or they can be transported to jail and subjected to the criminal justice system when what they really need is more help. Or maybe the treatment they're directed to is something like a hospital emergency room that is ill-equipped to address their needs. Alternative crisis response is the simple idea that we should pair people with the right response that they need for their crisis, and not to rely on a one-size-fits-all solution that asks police officers to do everything for every situation. It's the idea that if my elderly neighbor with dementia gets into an argument with a neighbor, that a counselor or a peer support specialist could come help diffuse that situation, that a noise complaint shouldn't result in dispatching necessarily an officer. Today, we're going to hear from several of the pilot programs that have been underway in our community to test this idea. And I have to say this, and I'll say it again throughout the hearing, I'm extremely proud of the progress that this city has made in truly a short period of time. But we're still only covering a fraction of the mental health, addiction, homelessness, and other causes which could receive some form of alternative crisis response. As we get started, I want to lay my cards on the table. I wanted to say today is about how we take the next steps and go from phase 1 to phase 2, from pilots to permanence, from multiple success stories to an integrated system that is poised for growth. It's about what does the next 5 years of public safety or 10 years of innovation look like for us as we advance these collective goals. Our community is ready for this. In 2021, a survey of residents found roughly 80% of residents said they were comfortable with a non-police crisis response for many of these kinds of issues. I believe that 5 to 10 years from now, we could be diverting some of our calls from 911 to various co-responder models to community responders. That does not mean that anyone is having any types of conversations about changing policing in our community away from traditional policing. I've been proud to invest in police staffing and pay this past year, but what it does mean is that we are specializing our police, freeing them up to be able to focus on what over 1,200 hours of specialized training in our police academy equips them to do: investigate dangerous crimes, address violence, and get guns off our street. Now more than ever, we need them to have those focuses. In the 2023 budget, we secured $1.2 million to help us plan for a broader system of alternative crisis response. That would include specifically helping us pilot a response program for nonviolent service calls like mental health, substance abuse issues that would train community responders to work in those situations instead of police officers. That program would be evaluated and, if successful, scaled up. It could also include creating and consulting an advisory committee of community members and behavioral health professionals who could guide us as we create this integrated system. What we learned today will help us decide how we move forward with these goals. Planning for the system of public safety we want Columbus to have, not just in 2024, but in 2020, 2030, and 2040 as well. So I am very appreciative that we have this group of folks in front of us. Like I said, the folks here have worked extremely hard to get us where we are today. And even in the briefings that I've had in the last couple of weeks, I've seen how far we have come. And so this is more of a excited hearing for me, because I think that when folks understand what we are doing, the services that we're already providing, they too will be proud and excited about where the path that we're on. With that, I'm going to turn it over to someone who is a fellow advocate for alternative crisis, for safety in our community, our Mayor, Andrew Ginther.
Thank you, Mr. President, Mr. Chairman. Thanks for allowing me to join you all for a few minutes now. I was just thinking as we were starting this, I chaired, as a rookie council member, the Public Safety Committee back in 2007. And thinking about some of the things that we're going to be talking about tonight weren't even contemplated, weren't even considered, certainly back in 2007, but to your point, Mr. President, probably even 5 or 10 years ago. And so I'm excited to have our departments and our partners here tonight to talk about all of the great progress we're making with alternative crisis response, and really appreciate Council's strong support and advocacy for some of this work. These programs we're going to talk about tonight really are innovative, and they're deployed to strengthen community safety, personal wellness, and mental health in a more holistic fashion. This aligns with and advances our comprehensive neighborhood safety strategy, which includes prevention, intervention, and enforcement. I truly believe Columbus is on the leading edge of this crucial work. As the needs and challenges of our community have shifted and evolved over time, so too have our resources, our services, and our partnerships to meet those challenges head on. Alternative crisis response represents the power of collaboration to lift up individuals and families to apply the best, most appropriate resources to a particular situation, and to leverage our combined strengths and expertise to maximize our collective impact. This approach provides a broad range of tangible benefits to residents and first responders alike. It connects individuals in crisis, especially those confronting mental health and addiction challenges, with the right resources at the right time of their crisis. It reduces our reliance on patrol and EMS for crisis response. Police play an important role, but they can't do it all, nor should we ask them to. And it pushes us to continually improve the ways in which city departments respond to calls for service. In short, alternative crisis response makes us a kinder, more compassionate, more effective, more robust, and more nimble local government. Tonight, you'll hear more about the various programs upon which this overarching philosophy is based. One that I'm particularly proud of is the Right Response Unit, which we launched as a pilot program back in 2021 and has quickly expanded to include additional personnel and hours of operation. It works by embedding social workers and clinicians in 911 dispatch to de-escalate certain situations and connect callers in crisis with the social services best suited to address their unique needs and concerns. This program has been a tremendous success. So far this year, the Right Response Unit has triaged over 3,000 calls. This volume helps to explain why we implemented a second shift last fall. Nearly 30% of calls handled by this unit did not require a police response whatsoever. Nearly 30% of the calls did not require a police response whatsoever. The right response at the right time for our neighbors in crisis. That also means that same 30%, our officers could be focused on preventing and fighting violent crime and responding to calls for service in our neighborhoods. Roughly 350 referrals have been made to our mobile crisis response team, another great resource for addressing mental health in our city. A non-emergency mental health line was also created to better address the needs of our community. We've recently seen the number of calls to this health line rise to nearly 1,500 per month. All of this has saved our patrol officers well over 1,000 hours, allowing them to dedicate more of their time doing what they were always intended to do and what they do best, take on violent crime in our neighborhoods. This is the added benefit of boosting the enforcement aspect of our comprehensive neighborhood safety strategy. Again, it's about prevention, intervention, and enforcement. As you can see, all of these pieces are interconnected. They operate both independently and in tandem to realize the very best services and outcomes for our residents. I know we'll learn more tonight about a framework that Department of Public Safety, Health, Office of Violence Prevention, the Mayor's Office are working for a common dashboard for the alternative crisis response services so that we can continue to report out to the community progress and success and data as we continue to grow this. We have such incredible opportunities, as I know Erica Clark-Jones is here, President and CEO of the Adam H. with the Adam H. Crisis Center that will be opening in the next couple of years. We've been a major funder and partner of the city as well as the county, the state, so many other partners of the community. That will be another game changer. And as we continue to build and develop the alternative crisis response, incredible opportunities to partner with Adam H. Into the future. You'll learn more about the Rapid Response Emergency Addiction Crisis Team, or RREACT for short, and the specialized program assessing resource connectivity, which is commonly referred to as SPARC. I'm incredibly grateful to my colleagues on City Council and our community partners for their steadfast support in launching these programs and helping to ensure their success. I'd also like to thank our first responders at CPD, the Division of Fire, Communications, and 911 Dispatch, Public Health, Public Safety, and so many others for always going the extra mile. Together, we'll continue to rise to the occasion, remain flexible, strategic, and collaborative, and proceed on our journey to make Columbus the safest big city in America. Thank you, Mr. President, Mr. Chairman.
Thank you so much, Mayor, and thank you to Council President Hardin. Thank you to our presenters in attendance today. We've got a robust group of people to report from all the different areas, including our Public Safety Director, Kate Bisciotti, our Deputy Public Safety Director, Dan Giangardella, Assistant Health Commissioner, Anita Clark, Community Clinical Counselor, Sally Smith, Support Services Administrator, Ken Kuntz, Police Sergeant Matt Harris, MCR Program Manager, Keith Paletti, Fire Lieutenant Isaac Tulliver, Fire Captain Matt Parrish and EMS Medical Director Dr. Robert Lowe. So as you can see, it's a great lineup of speakers and presentations today as we dive into this alternative crisis response. We will then hear from a few invited guest speakers before moving into the public testimony portion of the hearing. So to get started, without further ado, I will now turn the floor over to the first of our speakers to kick us off, Public Safety Director Kate Bisciotti and Deputy Public Safety Director Dan Ginther.
Good evening, Mayor, Council President Hardin, Council Chair Remy. There is no one-size-fits-all approach when it comes to public health and safety, which is why the City of Columbus has invested heavily in alternative crisis response. Guided by experts in mental health, substance use disorders, social work, and law enforcement, these collaborative programs cross departments and disciplines to provide better, more tailored responses to the needs of our community. This has only been possible due to the forward-thinking leadership of Mayor Ginther and this City Council and our outstanding professionals in public safety and in public health. They have enthusiastically embraced these challenges, showing an openness to reach across departmental lines and outside of the traditional ideas of emergency response. The results of these efforts have been overwhelmingly positive, and you are about to hear much more about them. From individual stories of residents connected to the right support for their specific needs, to a significant reduction in police responses, freeing up an estimated 1,000 patrol officer hours so that our officers can focus on their core missions of crime prevention and safety. We are proud of this groundbreaking work and will continue to prioritize innovative partnerships to find the best way to serve our neighbors in need. To help us dive deeper into these programs, please welcome Deputy Director Dan Ginther.
Thank you. Thank you, Director Bisciotti, Mayor Ginther, President Hardin, Chair Remy. Again, thank you for allowing us to be here tonight to talk about these programs. Some of this information that we will present are things that you have seen in the past. Obviously, this has been a very good collaborative effort involving 3 divisions in public safety, as well as 2 departments, including the Department of Columbus Public Health. So we also will have some frontline speakers tonight. And while we are here talking about this, we get to pub up these programs. In the meantime, there are a lot of really good city employees out there on the front lines that are doing the real work. And as I said, including some of those that you'll hear tonight. So with that, we'll go ahead and get into our presentation and talk a little bit about our alternative response units. And of course, the right response unit, which Mayor Ginther and President Hardin, you have talked about, which is the embedding of dispatchers and social workers in the right response unit in our call center. That is, we'll hear a little bit more about that in a minute, but that has been very successful. We have call takers and social workers and dispatchers that are there Monday through Friday, 8:30 till midnight. And of course, our other response units, mobile crisis response, which we'll hear more from, as well as RREACT and SPARC. Again, just some of the things we have done recently with our right response unit, which of course has reduced the number of hours that police have to be out there, also has impacted our EMS as well. And again, when this program was launched in June of 2021, it was just a Monday, I think we launched it initially with 4 hours with social workers from health department. We expanded that to 8, and then last fall that increased to 16-hour shifts. So with that, I'll turn it over to Anita Clark, the Assistant Health Commissioner, and other speakers from health to talk more in depth about the right response unit. Anita?
Thank you, and thank you, Mayor Ginther, President Hardin, Chair Remy. I'm so glad to be here, and I'm so glad to have one of our social workers here tonight, too, to share an incident with you. As Mayor Ginther had mentioned, we started a pilot program very small with a 4-hour period of time, and that was back in June of 2021. We now have the 2 shifts, which we're very pleased with. That is a shift that runs from 8:30 to midnight, as we mentioned. And Dan, if you would, go ahead and roll through the right response unit on the next screen there. Thank you. I want to talk a little bit about how the right response works. We talk about the importance of having the right response. And indeed, the calls come in either through the 4545, which is the non-emergency line, or the 911 call center. And I really have to say, again, this has been a collaboration with public safety as far as working with them to establish this 4545 line. I think it gives our community an option when there's a mental health crisis. So they either call either line, and the dispatcher reviews the call, finds out whether it's a situation involving mental health or substance abuse, and then triages that call once they get permission with the resident, whether they can transfer the call to the social worker. And in that RRU, as you see in this picture right here, you have a dispatcher and you have a social worker, and they stay on the line together to work through with that resident to ensure that they have the right response. In some situation, as Mayor Ginther had mentioned, we don't have to send police. In some situations, we do. In some situations, we have to dispatch fire, and that's okay. Because even though at times our social worker is on the call with that resident, they're de-escalating them before the police or fire attend that resident or knock on that resident's door. And I think that's important to say because they're doing some wonderful work in de-escalation. Sally and I, which you'll hear from her later, talked about that on our way here. And again, it's often where they're de-escalating, they're getting information from the resident on what's going on. So our police and fire walk into a well-known situation with more information than they ever had. So I just really want to point that out. And if I can go ahead with the next slide, please. We did take over 2,300 calls in 2022, and as mentioned, over 3,000 calls this year to date. And 30% without dispatching police. And then 371 follow-up calls, resources, linkages that we did with our social workers. And then the collaboration with our emergency communication center on developing that 4545 non-emergency line. We've resolved 867 calls. And we really think that even with estimated 1,000 hours of police time that we freed up, I really think that number is going to grow even more so this year with our 2 shifts. And on the next slide, we have some successes that we've done so far this year. There we go. One of the big things is creating a web page that we have on the city site, and we just recently went to a new platform, which was launched actually Monday. And I don't know, Deputy Director, if you're able to click on that link there to show our webpage. There we go. And down below, we have each of our alternative crisis response programs where we have residents that can click on each one, find out information about each program, as well as to be able to click on the contact information if they have questions about the program, they want to learn a little bit more about it and engage with those programs. The emails are checked on a regular basis from each of the programs that are involved, but we really wanted to be able to provide this to our community and give them a resource to getting a hold of us. Another thing that I'm very proud of is that we launched a new software with Columbus Public Health called Penelope, and it's going to help us to provide more data. And we just launched that this year, and we're working through some of the processes now, but I'm hoping by 2024 we'll have some excellent data to feed in to a dashboard that we plan to have here shortly, and I'll show you an example of that in just a moment. The other thing I wanted to talk about on this slide is our campaign that we're launching with a contractor called We, Us, Them, and really we want to get out to the community the need for mental health care, and also to talk about our services so they know that we're doing what we're doing and that they have the resources to reach out to us to provide them the right response. Right, the next slide. This is an example draft dashboard that we hope to have, and if any of you have reached out during COVID and saw the Columbus Public Health dashboard, this is going to really look very similar to that. And I've been working with all of our departments, police, fire, public safety, support services, to come up with numbers for this dashboard. and we're working very hard with our Department of Technology to get this launched here very soon. And our next slide shows a little bit of our mapping. That's kind of upside down T, where you see the heavy calls that come into our community and where they're located at. And then lastly, I want to talk about some success stories, and I'm going to turn it over here shortly to Sally Smith, who is one of our RRU social workers on our second shift. And before I do that, I have a success story up here that talks about just the interventions that we did prior to having police arrive at a resident's home. We had a mother who had been hallucinating, had a weapon, and our RRU social worker and dispatcher talked through with this mother while the police were en route, knowing that she had a weapon in play, and they were able to de-escalate that situation. So there was no harm done and no incident of violence when the police officer arrived. And I think that really that says a very big statement about what the social workers are doing in the RRU. And with that, I'm going to turn it over to Sally Smith, who has just a really unbelievable incident that occurred earlier this year. And if we didn't have this service, I'm not sure what the outcome would have been. So, Sally?
Thank you for this opportunity. I've been a clinician almost from the start of the RRU. I came about a month later, and I was working second shift one night when a call came in to our police non-emergency line, which, as Mayor Ginther pointed out, has a self-select option, option 3, to seek mental health services. And the call was answered by our dispatcher. And initially, the caller identified himself by his first name and said he wanted to report a shooting that had happened earlier that day. So our dispatcher transferred the call out to the main dispatch room, not really kind of knowing why he had self-selected that mental health option, but transferred it out. We started talking, and he realized fairly soon that he thought it was a gentleman that police were looking for in regards to that shooting. And so we kind of had that discussion. And then he called in about 10 minutes later, and I asked to be put on the call. And it was indeed a gentleman who had identified that he had shot his girlfriend. He wasn't sure at that point if she was still alive because he had fled the scene. As it turns out, he had managed to make his way into North Carolina and was driving around North Carolina and wanted to talk to somebody about what had happened. He was very tearful, and he said, "I know I can't take it back, but I need to tell you what happened." I immediately tried to figure out a way to kind of keep him on the phone, and he wasn't sure where he was, so I asked him if he could turn on his GPS locator in his car, and he did that and told me he was outside of North Carolina on Interstate 77, I believe. And his plan was to suicide by cop. He said he had guns on him and he was not going out in cuffs, and that he planned to die at the hands of police that night. I was able to talk to him and connect up with what had happened to him in his lifetime. I asked a simple question of what happened to you, and he shared that his own father had been killed in a police incident when my caller was 2 years old. He also shared that he had a 2-year-old and a 4-year-old and had an argument earlier that day with the mother of his children. And he felt that he later on said that he just snapped when the person that he shot had made a comment about his parenting. I talked to him about, he said he wasn't going to shoot any innocent people, and I explained to him that those officers and anybody caught in a crossfire would be innocent people, and that he needed to leave a different legacy for his children than his father had left for him. I told him that, his life wasn't over, that he did need to, he needed to turn himself in. I was able to convince him to GPS the location for the nearest police station. I stayed on the phone with him for over an hour while we negotiated his surrender, peaceful surrender. I was able to get him to not pull his guns and to have the officers detain him successfully. And I do believe, hurt people hurt people. And he had had a lot of hurt in his life. And And I feel like had we not been there that night, it might have turned out very differently. I just feel like that's kind of one powerful moment of how that changed the trajectory of what might have happened that night. We've had a lot of stories like that, but that one was very powerful for me. And I do feel very proud of the work we're doing out of the Right Response Unit. And it takes a whole team of people. So we're working with the dispatchers, and we have them there to help us. My dispatcher was on the phone with the county police where he was located. We were able to negotiate, different terms of him surrendering himself that night, and nobody was hurt further. Thank you.
Thank you, Sally, so much for sharing that. That's so impactful. Before we end with the RRU, I just want to mention that the collaboration that we've had, I have Ken Kuntz here, who's administrator with the ECC. He has made things happen here. We talked about Deputy Director Dan G. I'm not going to say his last name, but we're on the phone every day talking about issues. So thank you. And I'm going to pass that baton over now.
Okay, I think we're ready to move on to mobile crisis response. So first, I do want to thank Anita and Sally for those stories. I think it speaks to, we say 3,000 calls, but sometimes we underestimate the length of those calls or how much work is invested in each one of those calls. And of course, that was one example, but I think if they were to tell about a lot of their calls, these take a great deal of time to resolve frequently. So with that, we'll go to talk about mobile crisis response, which has been around for a number of years, the great work that the police division is doing. And with that, I'll turn that over to Sergeant Harris. Thank you.
Thank you, Mayor. Thank you, President Hardin, Chair Remy, for the opportunity to speak. So we've been running this program now for 5 years, and currently we are staffed with 5 police officers as well as a staff of clinicians from Columbus Public Health. What we're still finding at this point is that there's roughly 23,000 mental health related calls for service that are coming into dispatch each year. So that number has somewhat stabilized over the past 2 years. And currently, we're fortunate that 74% of the mental health related calls that are coming in are handled by either a CIT officer or an MCR team.
Sorry about that.
Okay.
It'll pick it up, and he'll have it on.
Okay, sorry for the technical difficulties here. Is this coming through? Okay, let me try it right here maybe. Okay, sorry about that. So 74% of the calls have been handled by either a CIT trained officer or an MCR officer. Currently, the MCR teams, because we are a limited resource, we're able to handle about 15% of the mental health related calls for service that are coming into dispatch each year. Roughly a third of those calls that we handle, that we respond to, require some sort of transport to a higher level of care, whether that be an area hospital, whether that be a crisis center of some sort. But we are trying to get that individual somewhere where they can receive care that is required. It's certainly beyond our limits, standing in somebody's living room. We're still averaging about 300 calls per month, or what the teams are taking, with about 80 to 100 transports to area hospitals each month. I will say that the collaboration with the Right Response Unit, with RREACT and SPARC has been incredible. And what we found is that because we have these other resources that specialize in substance abuse and SPARC, which can sort of fill in the gaps, and they're especially good with our elderly population, we sort of have wraparound for everything, which is fantastic because there's really not many situations that that come our way that we're not able to figure out a resolution for. RRU has been, I think they've exceeded my expectations by far, just because they have an ability to triage these type of calls and handle so many incidents without having to dispatch public safety. So then that leaves us available for the more serious type of situations that do have elements of danger. So the police teams are available. And I think we've had some success stories, and I'm going to let my clinical partner, Kareth, speak to those. I think, Kareth, do you remember Kyle?
There we go. I actually do remember Kyle. My name's Kareth. No, you're good. I am the program manager for the clinical side of mobile crisis. So yeah, actually Kyle was from out of state. Several of our units had runs on him over the course of several years. Basically, he was suffering from delusions. Actually had a GPS tracker that he didn't know about, like in his shoe, so that mom could kind of keep tabs on him as he came over to Columbus. A few of our officers and a few of our teams were able to ultimately, with a lot of work and in conjunction with, I believe it was OSU, I don't want to, mix that up, but with one of our good area hospitals, and we were actually able to get him into Twin Valley where he was able to get stabilized. And this was after like years of like delusions running across the country, mom not knowing where he's at. So after stabilization at Twin Valley, actually she had sent pictures, I believe to you, Sergeant Harris, about, hey, here's Kyle, here's how good he looks, here's how well he's doing, and he's back engaged with family. So that was an example of some stuff that MCR can do. We've done things from kind of like the more, I don't want to say massive, but things from like, being able to help talk somebody off of a bridge, just to the average everyday things of, hey, son's having problems with mom, son has a history of domestic violence that's starting to escalate, MCR shows up, we're able to kind of level with the guy that's in crisis, kind of bring him down. And then one of the big things that we try to do, I think, as a unit is if we can make it your idea and not only give you choices, but make it your idea that this would be a good idea for you to go see somebody and talk to somebody, get help. I think that's one of our ultimate goals. If we can't de-escalate within the community, then the goal is, hey, let's get you somewhere and get you some help. And where would you like us to take you? So that's, I think, a few examples of MCR.
Thank you, Sergeant Harris and Kareth. And our next responder group. Got to go the right way here. Would be our REACT team. And with that, I'll turn that over to Lieutenant Tolliver. Thank you.
Thank you. President Hardin, Safety Chair Remy, thank you for this opportunity to talk a little bit about the REACT team. So we are a branch of the EMS outreach within the Columbus Division of Fire. We're a secondary responder team with primary response capabilities. We are a collaborative, so we have firefighters, paramedics on the team, along with Columbus police officers. We have clinicians, social workers, and peer supporters as well. The REACT team has three main areas of focus. The first one being prevention and harm reduction. Over 2022, we went to about 145 community outreach events. We were able to distribute 2,500 Narcan kits, where we actually do a lot of education, a lot of training, and we actually give out the kits. Hands-only CPR. We just do a little bit of everything to try to get resources to the community when we're out in the community. The second area is connection for treatment and resources. That's probably what we're best known for, going out, knocking on the doors of non-fatal overdoses and trying to engage the individual and just connect them to whatever resource is going to be appropriate for them. Last year, we had direct contact with about 650 people that had non-fatal overdoses and another 300 family members that we were able to talk to, and just leave products behind, whether it's harm reduction or just our wristband. So when someone's ready for treatment, they can give us a call and we'll come out, pick them up, take them to whatever's going to be appropriate for them. Lastly, we do a lot on the recovery and support side, and this is what kind of sets our program apart from others across the nation. We have an alumni group, and when we talk about those success stories, we see them monthly. Once a month, we host sober events for people that we got into treatment, and also just anyone who's in treatment and just looking to do activities. So we host a bunch of different ones. Like I said, it's every month. We'll have people with 2 weeks of sobriety to 4 years of sobriety, and just seeing the journey that some of the people we've been able to help has been great for our team, great for the individual. We have people who have become peers. We have people who've gotten their families back together while they're going through sobriety. So it's just a really good journey, and lucky enough to have a great team that is passionate about the work, passionate about the community, and just trying to get the right resources for the people that are out there. Lastly, we do training. It's Dr. Perry's neurosequential response stress training, and we do that for our first responders, some of the medical profession, as well as some clinicians. We've hosted 16 of them in 2022, and it's just a great opportunity for us to sit around, talk about the stress, talk about trauma, so we can take care of ourselves, as well as trying to take care of the citizens in the community. That's it for the REACT team. Thank you very much.
Thank you, Lieutenant Tolliver. We also have on our website a number of videos, including this one that we're about to show you. This one deals with the REACT team and gives you some inside experience on what they see when they go out and how they help the community.
It's a lot of knocking on doors and not really knowing what's on the other side.
All right, thank you.
Coming to policing, there's a lot of seeing where you fit and seeing where you can do the most good. My name's Rachel, this is Brian. We're with the Columbus Fire REACT team. When I started with CPD, this job didn't exist, and I'm telling you now, it's my dream job. He's just got to say, I can go today, I can make this commitment. I'm Officer Rachel Thomas. I've been with the Columbus Division of Police for 9 years, and I'm a member of the REACT team. That ended up being an overdose. REACT is the Rapid Response Emergency Addiction Crisis Team. What we do is we get referrals and respond out following a non-fatal overdose to assist the person who has experienced the overdose in getting into treatment if they are ready, and to provide harm reduction like Narcan or naloxone and fentanyl test strips. Opiates are being put into just about everything now. This is a way for them to tell whether or not what they are choosing to consume may have fentanyl in it. Straight out of college, I was a social worker. I worked for a nonprofit called the Buckeye Ranch, which was a great experience, and kind of got looking around what's next, what do I want to do, and what's my skill set? One of the special duty officers at the ranch said, Rachel, you've really got to go do a ride along. You've got to experience what this is and how you can make it yours. And I did not believe him until I did the ride along. And the things that I was seeing, it defied kind of what I expected. I thought from television and my experiences as a caseworker that I knew what police work was. He was stopping to talk to people, to check on people, and this is third shift, so middle of the night, and we were in the Linden area, and he was doing all the things that I didn't really know police officers did. So it gave me an opportunity to see, wow, that fits with my values, that fits with how I want to interact with the community and what I want my job to be. I applied at the next window for applications and went through all the steps and finally got on in 2013. The epidemic hasn't slowed at all, and when things went from heroin use to fentanyl, the deaths really took off. So the problem, it's not going away. If anything, it may be getting worse. Peel, place, plunge. So peel it out of there, place it up the nostril, just plunge the plunger up. It's that simple. I have had people in my family that have needed to get treatment and have had to kind of walk this path. When you see that up close firsthand with somebody that you've known, it makes you realize how difficult this whole thing is, and nobody's choosing to use and to stay in a life that is obviously not good for them or anybody. We treat everybody like somebody out of our own family or our own friends, how would we deal with this? You gotta take care of you just as much as everybody else. The best days are the days we get to take somebody into treatment. If you can take and treat the substance use disorder, all of the things that, you know, the low-level crimes, the overdoses, the calls for service go away when that person is functioning better, which is to say nothing of the wonderful impact on their family, on, you know, their neighbors, the community at large. The rewarding thing is knowing that we have so many people that are, you know, living healthy lives. Their families are making steps to be, you know, more functional, more happy. It's so rewarding, and it's so neat to be able to regularly see people on the path to succeeding and doing better for themselves, even if we're just a small part.
Okay. Thank you. With that, then we will move to our other responding unit in fire, our secondary responding unit called SPARC. Captain Parrish will talk about that subject. Thank you.
Thank you, President Hardin, Chair Remy. You know, 911 was created to report house fires and heart attacks, and we have highly trained firefighters and law enforcement to respond to those critical emergencies, solve your problem in 10 minutes or less. And I think what we've heard tonight is just how complex and the special skill set required to do this alternative work, and why it's so important to have these specialty teams work together in collaboration and coordinate our response and effort. You know, as a new firefighter 30-some years earlier, I often realized that I was not who the individual needed when they called 911. I also recognized that fire couldn't do everything by themselves. We had collaborations with agencies like Red Cross to come in and provide resources after a fire, another collaboration. And I think that's the ideas that kind of spurred these secondary co-responder, co-response projects. And the safety still will ultimately be the safety net, and making sure we have specialty teams when it exceeds the community response or these other responders' capabilities is super important when we are called in after we've exceeded their capabilities. But the SPARC program, along with MCR and REACT and Right Response, is a collaborative effort. We partner with COAAA to respond to individuals who are identified through 911 calls that they need something other than a trip to the hospital. And that could be everything from housing to food insecurities to mental health, substance use disorder. Every time I think I've heard it all or seen it all, there's something else there that surprises me. But SPARC does follow-ups. I think a couple of the programs mentioned how much time these cases take to get and work with the individual, to get to the root cause, figure out what social determinants of health are causing this. And amongst, you know, doing that work, we connect them with the right resource at the right time, at the right expense, and for the right reasons. And just some highlights of what SPARC has done. In 2022, they received over almost 2,200 unique referrals, individuals who had either, maybe it was only one 911 call that they needed help with, or maybe they were a frequent utilizer of 911. And we were able to connect those individuals with those resources. Ultimately, with our higher utilizers, who, because they call 911 because somebody's always there, somebody always answers the phone, and there's always somebody that's going to show up. We showed a 41% reduction of our highest utilizers. And that frees up those extra man hours to respond to those house fires and heart attacks, those time-critical calls. Our partner, COAAA, they do specialize in older adults. A lot of our referrals are for the aging community in Columbus. I think it's over 65% are for older adults. And a lot of times they don't have the resources, or they don't have family, or there's a lot of isolation in that demographic, and we're able to connect them with those resources. And I just wanted to mention that just recently, I think today, the state was meeting to require dementia training. We become part of Ohio Administrative Code for all EMTs and firefighters, so they don't respond to, as President Hardin said, his elderly neighbor with dementia and not understand what's going on. So it's all about the collaboration and the coordination, information sharing, and working together to provide the safest community for Columbus and its residents. Thank you.
Thank you, Captain Parrish. So we do have a slide here on the 988 integration. And when we met last before council, which I think was in November, we weren't really sure what the impact of 988 would be on the demand for our services. And of course, now it's been about a year. And I think when we look at numbers, candidly, we're still seeing a significant number of calls to our 911 and our 4545 line. So, and I think there was also an article, I want to say, one of the local media did a brief spot on 988, and I think they were reporting 1,400 calls a month. Now, I don't know if that was statewide or for the local area or not, but obviously we're seeing those kind of numbers ourselves just through here locally in Columbus. So I guess, obviously there'll continue to be collaboration with them. But obviously, I don't think we've seen any decrease due to the 988 crisis line. Then items being addressed, some of these things we've talked about already, but I think it's important to highlight that we continue to hire 911 call takers and dispatchers. Obviously, they are as we say, the first of the first responders. We need to have them in order to have some of this success. So we continue to do that. We continue to have success hiring individuals to dispatch. Commissioner Clark talked about a media campaign, and we're happy to collaborate and share funding for that. And we know that that's moving forward. I think it was council's already legislated that contract, so we'll have that sometime first quarter 2024. Vehicles, we have on order vehicles. We also have bids coming in for vehicles for these responder units. And then, of course, I think we'll hear later on tonight from Adam H. and their plans and what they'll bring to the community for these programs. And then, of course, the website, which went live a few months ago, and then the upgrade to that website, which went live this week. And then lastly, the upgraded protocols, 911 protocols, our software for both police and fire, and of course, the potential for a nurse line. So with that, I will have Dr. Lowe, our medical director, speak to the upgrades in software for the protocols and the nurse line. Dr. Lowe?
Thank you, and thank you, Chair Remy and President Hardin. What we wanted to touch on here a little bit is just building on the next steps. We've talked about expansion of these successful programs, but we also talk about how that encompasses the whole health of our patients and our community. And so what we're looking at doing is becoming more nuanced in our ability to identify folks who would benefit from a tailored treatment, if you will, a tailored program. And by upgrading our triage ability, our call-taking ability, what we're looking at is the ability to then match the response to what's appropriate. To Captain Parrish's stance, is that a heart attack or a house fire? Is that more appropriately an RRU response? Is that a mobile crisis response? Or is that additional responses that we will develop from the health side and from the referral sides? So the first step in that is knowing that we are safely making those decisions, and that's where that protocol is important, where that software intake is important to be able to sort folks out with a reasonable amount of certainty that it's okay to go down this treatment pathway versus that treatment pathway. That work is ongoing. We expect to come to council in the near future with what those contracts look like. Beyond that, we look at something called a referral line. We commonly refer to this as a nurse triage line. But I think what you've seen is one of the successes out of programs like RRU is that ability to refer to a specialized program referral line that can handle a problem probably more adeptly than either the response and or often than the destination. Just like not everything's a house fire, probably not everything is an emergency department patient as well. That may be an unfair burden we place on a number of our patients by taking them to the most expensive healthcare option that maybe is not the quickest option as well. And so as we tie all that together, those are the resources we look to proceed in the future. I think ultimately to sum all this up, what all of our programs are saying and what we're moving forward on is there really is no wrong request for help. We are just trying to align people with the right care in the right amount of time.
Thank you, Dr. Lowe. And then finally, the design of our new call center, which will, of course, include the right response unit. And I point this out because obviously when we launched the right response unit 2 years ago, we had to make a variety of accommodations and fit them into the call center. Call centers weren't designed for that. So obviously we're excited about this going forward, that collaborative effort. So when that architectural contract begins and when that facility begins to be designed, it will include the RRU. And of course, any progress that we make from here to the opening of that facility, obviously will include those benefits in there as well. So with that, that pretty much concludes our presentation, and my colleagues and Director Picciotti be happy to answer any questions that council may have.
Thank you very much, Deputy Director, and thank you for everyone for your presentations here today. I want to direct my first question to Director Picciotti. Just what's your vision of Columbus Alternative Crisis Response and our partnerships as we move forward?
These microphones are a trip tonight. Council Chair Remy, my vision is that we continue to collaborate and we're working together so great cross-departmentally, but at a certain point where these different programs report to a certain department. So we're looking at where that should go, where it would be most efficient, and how that reporting structure would work. But we want to continue to look into additional ways that we can respond to the community in the best way.
And Captain Parrish, I know we had a little conversation in the hall, but certainly talking a little bit about that relationship with SPARC and COAAA and what the future holds. As we've been hearing, it might sound better to be in-house, and so I just wanted to hear a little bit more from you.
Yeah, like I mentioned, a large number of our referrals are with the aging community. And when we started this program, fire didn't have a job classification for a social worker. So we started, I went to my partners in the city and said, where can I get a social worker to come work with us? And Health had a lot of programs. They didn't have extra staffing. We met with COAAA, and they really helped us get this off the ground and running. Where that may end up down the road is if there's an opportunity to create that classification under fire and have them as fire employees. There's a lot of benefit to having operational cohesion, but there's also a lot of benefit in having cross-collaboration amongst agencies and sharing information and resources. It's so important today with the labor shortages that we don't have everybody doing the same work, right? That's how you're going to expand your resources, is utilizing those clinicians to their fullest capabilities. Whichever way we end up going, we will always have that partnership and collaboration. And but as a city-funded program and where, like Director Picciotti said, wherever this may lay, there's a lot of benefit for operational cohesion to have those as our employees.
Thank you very much. And Assistant Commissioner Clark, mental health is such a huge piece of the public safety puzzle. Curious what you guys talk about at Columbus Public Health looking into the future regarding alternative crisis response systems and partnerships. Like, what does it, if you had your ideal situation, what does it look like moving forward?
Chair Remy, I think we all know that the volume of mental health needs in our community is huge. And so we're constantly talking every day about how we're going to meet those needs. I think we need to continue to look at the data and really be evidence-based on what's working. We've done pilots, and I think we just need to be very aware of that data and really look at it to find out what we need to do next. Next steps, I think City of Columbus is very unique, and I'm very proud of the work that we've done here. And I think that we're meeting the needs, and it certainly still is not enough. And I would say if I'm looking at 5 to 10 years, we still need more social workers, and we're going to need to do some recruiting and pipeline work to recruit social workers, because it's very difficult at this time for social workers and clinicians to hire them. So that's some work that we need to do in the future.
Thank you very much. And I want to jump back to the nurse triage line. I'm such a big fan of this and really been pushing that, it doesn't come soon enough in government. But, as we talk about all these programs and diverting calls from, for instance, police officers so that they can do the job of fighting crime and solving crime, this nurse triage line will allow our paramedics and firefighters to do what they do best as well. And so if you could just go over a little bit of the highlights of that and what that means as we move forward into 2024.
Certainly. I believe our concept here is one, again, kind of matching the resource. And so a highly trained paramedic is very good at life threats, cardiac arrests, and things that need action immediately in the field in austere environments. There are any number of other health urgencies, non-emergencies, but no less important matters that we realize maybe doesn't fit the perfect skill set. Maybe it's not something that's actually covered in the paramedic curriculum. Much like there's specialties in medicine, paramedicine is a specialty in and of itself. And so the use of a line where we can appropriately triage someone to transfer them to, for lack of a better comparison, an RRU line for health, to begin to talk through that. What are your next needs? What are we dealing with in the signs and the symptoms? How does that resource connect? And that resource, just spitballing, may be an immediate telehealth appointment. It may be scheduling an appointment the next day with appropriate resources for that. It may involve a transfer back to 911 for a transport or a non-urgent transport. It may involve other sort of counseling and resources and options for obtaining care in the moment and obtaining ongoing care, and that's kind of our vision.
And I can say it probably better than you can. We have a you call, we haul mentality. So we're literally transporting people to fill prescriptions in the emergency room. Not sustainable, and certainly one where we've got to look across the board with people resources, and certainly even on our equipment. If you're running calls like that all day long, and you are, wear and tear on our vehicles where lead times have doubled, costs have practically doubled, and certainly we are in a post-COVID world where we have to be smarter in how we answer this. And by the way, the level of care that our residents will receive when we get this nurse triage line will quadruple, just because it'll be the right response for the call that's coming in. So I appreciate the work that's being done to set that up. Council President, do you have any questions?
Thank you, Mr. Chair. And again, thank you to the folks that are doing the work, the folks that are represented, but even more so the folks that are on the front line answering the calls and providing the level of response that I think our residents have really been asking for and deserve. They are our client, and at the end of the day, it's about making sure that folks get the services that they need, the appropriate services that they need. I have several different lines of questioning. One, so it's no secret that publicly and privately I have advocated for a non-police pilot. We have done an amazing job over the last 2 years of piloting several different response types and response styles. And as we think about how we are now, as Dr. Lowe is working to look at the nurse triage line and figure out what calls go where, how do we think through how another pilot, like a non-police pilot, would even operate? What are the first steps in how that would even come along? I have said, again, publicly and privately, the one concern about pushing this too hard is that, or aggressive fast, is that we are piloting several things at the same time right now. And I do worry about, overburdening a system that is changing rapidly already. When I've been in office 9 years, I've been in this building another 5 years on top of that. We were not talking about some of these things several years ago, just at all. And in a very short period of time, We have added these new services and we have scaled these up. So again, as a legislator, as on the policies side, you guys are the implementers. Director, how would one engage as we want to, as I talk about this interest in a non-police pilot? And again, this is not an anti-police statement. This is one, how do we make sure that our officers go to the places that they need to go when they can go, but also how do our residents get the right services from the best person and not duplicate services, duplicate officials going out at different times? How should I be thinking about this as a legislator?
So, Council President, I appreciate, when you make the point that we would be freeing up police officers to do the work that that we need them to do. I would probably turn this over to Assistant Health Commissioner Clark because it would be a non-police response and it would be more clinicians that public
Fair.
health would probably be able to talk to that a little better than I.
Thank you, Director.
Thanks, Director Pesciatti and President Hardin. I think it's a great question, and I think that I had mentioned the data and evidence. I really think that we need to see, we have some great partners in the room today that have a community non-police response teams, and I think we're up to 4 now in the community. So I really would want to look to them to see what the needs are and whether they're being met. And then once we determine that and what the gap may be, then we can look maybe internally to say, what is needed here for the city of Columbus to do a non-police response team. But I would really want to look at those 4 teams, and some of them are fairly new. And we're working with all of them at this point. So that's where I would like to get started. And then it would have to also be such a collaboration, even though we say a non-police response, in my heart of hearts, we'd still have to, I would want to outfit the social workers with radios that they could easily equip themselves to get a hold of police. So it's still going to be a collaboration somewhat with police as well. But that's the first steps I think that need to happen.
Thank you, Ms. Nita. And I do spend a lot of time thinking about the organization. How do we work together? This is a cross-departmental, and as you just said, Director, now even outside of the city services. We talked a little bit about it. I think the triage is a part of that. How are we thinking around structure and org? So again, this vision we talk about 5 or so, 10 years from now, where you have a 911 or a police, a fire response, and a right response or alternative crisis. How do those what is our vision for how those things align going forward in the organ structure?
Thank you for the question, Council President. I think that when Public Health convened a group to kind of talk about where we go in the future with these types of programs, one of the recommendations was for an Office of Violence Prevention. And I believe that we can say that we're looking toward how this structure would fit under the Office of Violence Prevention without overwhelming them right now because it's so new. But that's kind of the direction we're looking to put the whole structure under the Office of Violence Prevention.
Thank you. Thank you. When we think, Ms. Nita, I think someone had spoke about, I think it was MCR, being able to respond to 15%, I think it's Sergeant Harris, 50% of mental health calls. As we take programs from pilot and try to scale them up, how do we identify when we operationalize the program? So it's not able to do 100% of the time. It's only able to do 15%, and maybe for right response, it's not able to do 100% of the time. It's I heard 8:30 to midnight. How are those based off of data that says this is when the highest need is? Is it based off of staffing availability? Like, how do we come up with, as we are in these pilot period, when we operationalize these services?
Thanks for the question, President Hardin. So When we started the pilot program for MCR, we looked at several things, heat maps for locations, but primarily the days of the week and the times during each day where the mental health related calls for service would peak. So when we looked at the graphs and the charts, that's how we based our staffing model. And those stats have stayed relatively the same. So the peak times for mental health related calls for service in 2018 are still very similar in 2023. So we designed the program around those numbers. Does that answer the question?
Yes, sir. Yes, sir. Is that the same, Director Nita? Is that for our right response?
With the right response, we've noted, and hopefully we'll be able to include this in some of the dashboards when the calls come in. You would typically think that the calls would come in maybe highest on the weekends, but what we're seeing is really during the week, Tuesday, Thursday. Sally and I just talked about that on the way over here, which is we really don't know why, that those are the highest calls and why they come in that way. So that's why we have it, the first shift and second shift Monday through Friday. Is there a need maybe for weekends? Yes, but I certainly would want the data, and I'm kind of looking at Ken Kuntz on that before we would implement weekends. And then I have to be quite honest, I think that recruiting for weekend social workers or clinicians will be very difficult. So we'll have to really think about how we would want to recruit for that as well.
Thank you. And then, Director, my last question, the question I asked last time we came together was just around budget. As we think about where we are now and where we want to go, and maybe even this is not a budget hearing, and I know that I don't think that you guys have given all your requests into the administration for funding, but how have we scaled this up in terms of a budget allocation, and what do you envision an ask, an increase as council prepares to receive the administration's budget in
Council
a
President.
couple weeks?
Council President, the man to my right has all the answers. I'm going to pass it to Deputy Director Gian Gardella.
Sure.
President Hardin, Chair Remy. So I think, and yes, you're right, Council President, you've asked each time. I think when we first scaled this, the pilot programs, we were in the $3.5 million range. And so when I look at what we're looking at for 2024, just for where we're at today, meaning, public health and public safety, we're just about $7 million in that, invested in that program. And so the mayor has been, and council both have been generous in offering funds for expansion opportunities. And of course, the nurse triage line will be something that I think we have funds budgeted this year to continue that, even if we contract for it next year. The upgrade of software protocols, which again will be coming to council here soon for that, and then the vehicles. So I think beyond that, it'll just depend on, like Commissioner Clark said, do we look at weekend staffing for social workers and clinicians, and of course, what impact would that have on call takers and dispatchers? I believe, if I remember, that the mayor proposed and council included in this year's budget 5 additional dispatchers. So we've gone from roughly around a $3.5 million budget 2 years ago when this was, again, more a smaller group, to a little over $7 million today. And obviously, as you know, the mayor will be submitting his 2024 budget here, I think, by code November 15th. So we'll anxiously await what that looks like for next year.
Thank you very much, Council President. And again, thank you for the responses this evening. Now I'd like to invite 3 fantastic community partners to share information about their organizations and how they fit into Columbus's alternative crisis response system. First up, we have Erica Clark-Jones, the CEO of the Adam H. Board of Franklin County.
Council President Hardin, Committee Chair Remy, thank you. Thanks for having us tonight and including us in this really important hearing for the residents of the city in Columbus and, quite frankly, our central Ohio region. My name is Erica Clark-Jones, and I serve as the CEO of the Alcohol, Drug, and Mental Health Board of Franklin County, or your ADAMH. Just as a reminder, ADAMH does not provide direct services. Our role by statute is to plan, fund, and evaluate our community's mental health system, and we do that by funding over 30 community-based agencies to be the behavioral health safety net for Franklin County. ADAMH, I can't tell you enough how I think it's a good time to live here in Central Ohio. Just everything we've heard tonight, the way that we are collaborating across systems is really important, and I commend your leadership, Council President, the leadership of this council, and quite frankly, the will of the mayor and the administration to make sure we get this done for our residents. So we are also grateful for the ongoing collaboration as ADAMH works to improve the entire behavioral health crisis care continuum. That's what we call it anyway. It means we prioritize meeting people where they are with the most appropriate response for their individual needs. So our goal is that every resident and every visitor to Franklin County has someone to call, someone to come or respond, and somewhere to go if they're experiencing a mental health or addiction-related crisis. And I think collectively, what we've heard here tonight, what you'll hear from the partners that will come after me, and those that are not here tonight but will be representing some of their work, we are getting better at this. So someone to call. You've heard a little bit about 988. 988, the new 3-digit, easy-to-remember number that serves as our national suicide and crisis lifeline, was launched in Ohio and fully adopted by our board in July of 2022. Forthcoming, there will be a statewide campaign on 988 so that we can encourage more usage of that telephone line in the future. Anyone who is experiencing a behavioral health crisis can connect with a trained crisis professional 24 hours a day, 7 days a week, via call, chat, or text at this time. In Franklin County, we have 2 local agencies that run our 988 call line, and that includes North Central Mental Health Services, located right on North High Street in the Short North, and Net Care Access. They serve as both our primary and backup operators, and you'll hear from Dr. Brian Stroh later this evening. In 2023, just this year, our local 988 call centers do receive, and I've heard this quoted earlier tonight, over 1,000 calls per month, and that is without any community promotion at this time. So we do anticipate increased call volumes as early as 2020, as people know more about the number, including in 2024. The majority of 988 calls can be addressed while callers are on the line. I think we're also hearing that from the right response units. Other times, though, callers may require an in-person intervention. This emphasizes the need for mobile crisis response teams, which fulfill the someone to come function in our crisis care continuum. So mobile response, we've talked about it from the Columbus side, City of Columbus side, but here's how we view it from the ADAMH lens. Anyone who has experienced or assisted anyone experiencing a mental health crisis would consider them to be emergencies, and we recognize that. However, as you've heard, most cases are not considered to be public safety emergencies. That work is being led by the City of Columbus to embed clinicians with police responders, and it is complemented by other available mobile crisis programs that ADAMH and the state of Ohio supports. So, for example, youth, a population we haven't talked much about this evening. In response to services for youth under the age of 21 who are experiencing a behavioral health emergency, Nationwide Children's Hospital now operates a mobile response stabilization service. They currently operate from 9 a.m. to 11 p.m., Monday through Friday, and respond to a crisis anywhere in Franklin County. ADAMH helped set this service up, and we monitor the performance of this program. Community teams. In January of just this year, ADAMH partnered with NetCare to launch a county-wide pilot community of 5 mobile response teams to serve all of Franklin County. Now, we recognize we need more, and you'll hear more about that here soon. However, just give me just one moment here. So yes, we've launched, we launched funding for 5 mobile response teams to serve our county. These teams are composed of a clinician and a peer supporter. And they're dispatched through the 988 call center when an in-person intervention is necessary. Thanks to additional funding that we've received from the Ohio Department of Mental Health and Addiction Services with the use of their state ARPA funds, it allowed Adam H. to help right-size the number of community mobile teams beginning or throughout 2024. As well as we use those dollars to purchase 6 what we'll call community-marked cars for CPD's mobile crisis teams, and we've worked with Columbus Public Health to make that happen. As you will hear next from Dr. Brian Stroh, 7 months of data collection reveal 364 completed community mobile team runs in Franklin County with an average of 76 minutes spent on scene to triage the individual that is in crises and helping to determine the next best steps for care for that individual. The most common resolution for individuals in crisis is connection to a higher level of care, such as an emergency department or an immediate substance use disorder service location, such as Mary Haven's Addiction and Stabilization Center, which you will also hear from our community partner tonight, Oyama Garrison from Mary Haven. The second most common resolution is that an individual remains in the community, but is linked to services with a follow-up by NetCare to ensure that linkage occurs. When individuals do need a higher level of care, it's critical for our community to have a safe place to go, which underscores the significance of the building of the Franklin County Crisis Care Center. The Crisis Care Center will be our community's preferred and centralized destination for individuals to go who need more specialized behavioral health care. With the generous support of Mayor Ginther and this Columbus City Council with your leadership, President Hardin, also the Franklin County Commissioners, the Central Ohio Hospital Association, Osteopathic Heritage Foundation, and several public and private partners, the Crisis Care Center is currently under construction at the West Edge Business Park and is scheduled to open spring 2025. So what's next? Adam H. has a bold vision of redesigning our crisis care system to ensure better outcomes for the people we serve. In addition to what was mentioned, our Adam H. Vice President of Clinical Services, Sue Valillo, convenes a 988-911 work group with partners, several in this room and seated behind me, that includes 988 responders as well as Columbus Public Health, as well as our 911 call center representatives from the City of Columbus, the City of Grove City, and the Franklin County Sheriff's Office. This group is launching another pilot program, which will embed 988 responders in the Franklin County Sheriff's Office in the Grove City 911 call center. And this will be done to develop standard operating procedures for 988 911 transfers so that no call gets dropped. We will share what we learned from this pilot, not only with our local partners, but our statewide partners, because we believe this will be innovative work. Lastly, on October 17th, just a few weeks from now, Adam H., actually 2 weeks from tonight, Adam H. is hosting a conversation with National Crisis Call Center expert John Draper, who will share lessons learned in getting the most out of comprehensive community call centers for the community's benefit. In closing, in order to build a truly integrated crisis care system, we know it will require a truly collaborative approach. I think you all have hit on that tonight, and we want to be a part of that. Not only that, this collaborative approach is going to have to come from many stakeholders across many different systems. Adam H. looks forward to our continued partnership with the City of Columbus in this work and all of our jurisdictions in Franklin County to ensure that any individual in Franklin County has someone to call, someone to come, and somewhere to go when they're in a state of crisis. And I'm happy to take questions at this time.
Thank you very much, and thank you for your leadership. We appreciate the partnership, and certainly want to ask, what can we do, what can the City of Columbus do to better coordinate and share information with partners such as Adam H.?
Yeah, actually, you all have been great partners so far. I think just this whole community effort where we're collaborative, we work with everyone, like I said, that's seated here tonight and has spoken. We just want everyone to stay at the table as we work through we continue to define what a community solution looks like, and we're not duplicative, and we're sharing resources. The other thing, and I think Assistant Health Commissioner Anita Clark mentioned it, is data sharing. We want to be informed by the data, by the trends that we're seeing, so that we can allocate the right resources in the right places. So I think both of those things are critical.
Super excited about this new crisis center, of course, and I think everybody is, but could you restate like how important that particular piece is to the system itself?
Absolutely. You know, when we think about our crisis care continuum, and our Ohio Department of Mental Health and Addiction Services feels the same way. There are better crisis care provision efforts happening all over the state. This will be no wrong door. Anyone can come and present 24 hours a day, 7 days a week, right here in our central city, in our housed in our Franklinton community, where anyone can come with a mental health or substance use-related crisis. We are expanding our community capacity by having space for 60 individuals to be treated at any one time under observation. And then we have the ability to host 16 beds for inpatient care for short duration before we find the right place in our community. That's an expansion of capacity that we haven't had in a very long time. We're grateful for our hospital partners, both public and private, that have stepped in, and our community partners that really treat individuals over the long term. But we want people to come to a place where it's full of dignity, we respect their journey, and build relationships with our professionals in our community that keep them linked to a support service so that they can recover and heal.
Yeah, thank you very much. Council President?
Thank you, Chair. Just quickly, and thank you, we're really excited about everything that AdamH is doing right now. It seems cutting edge, it seems on the front line. How far are we away from a person, regardless of what their issue, be it mental health, be it any of these, calling one number and it being connected to all of these systems and they just getting the service they need? I mean, that's what we're going for, right? And the next step to that is there a community ahead of Columbus that we can look to, just so that we know that we're on the right track and can anticipate how far out we may be to that day?
Yes, thank you for the question. We debated whether or not I should talk a little about that tonight. I think ultimately we would love to get to a model that I think has been used in Atlanta, and they call it care traffic control, where you call one number, and at that point you can be linked to services. We know exactly where there's open beds, and we're able to direct an individual to the proper resources where folks will receive them, and we can monitor what's happening all over the system. But I do think that comes from a coordination of community assets, so that when we do expand the capacity of a one-stop kind of call center, we feel very confident in the resources that we are making reference to. And so when you say how far away, I think it does come shortly after we open the crisis center. I think it's when we've got good data from our public safety partners, as well as our own data from 988, to be able to say, okay, what's the next best step? And Mr. Draper, who is coming 2 weeks from now, he's been in that space. So we're going to be learning from him. So I don't think it's far off. I would like to say it will happen. My hope would be within the next 5 years, but you're welcome.
Thank you so much. We appreciate the testimony this evening.
Thank you.
Next, we have Dr. Brian Stroh, the CEO and Medical Director of NetCare. Mr. Stroh, Dr. Stroh, welcome.
Good afternoon, Council President Hardin and Committee Chair Remy. I'm Brian Stroh. I'm the CEO and Medical Director of NetCare. We're a 51-year-old behavioral health nonprofit in Franklinton, and we specialize in providing care to those who are in crisis, as well as those who have high levels of ongoing need. I'm honored to be here talking with you tonight about alternative crisis response, as that's the line of work we've been in for most of our existence, and I'm happy to share our experience. Probably more than anything, the pandemic went a long way in pushing us as a community, as a region, and as a nation toward healthcare models that didn't revolve around buildings. For decades, we've operated a 24/7 mental health and substance use hotline at 614-276-CARE. Several years ago, having been well aware how tightly housing, and more specifically the lack thereof, plays into one's emotional well-being, we additionally became the Community Shelter Board's contract provider of the homeless hotline. That meant, for the first time, there was at least some unification of two different systems of crisis care under a single roof. Fast forward a bit, and we became providers in the 988 system just as that 3-digit number was being implemented and publicized. Today, we serve as the backup center for Franklin County phone calls to 988, with North Central Mental Health being the primary answerer. And we are poised to answer half or more of the 988 texts and chats that originate from all around the state in 2024. We make or take more than 150,000 calls, chats, and texts annually among all of our lines. I tell you all this because I truly see this as a web of networks, this web of networks as being one of the first steps to a truly comprehensive alternative crisis response model. Not to take away from any other program discussed here today, and frankly, not to humble brag, but the data from our call centers is truly impressive. 87% of behavioral health calls, texts, and chats originating from 988 and 276 care are resolved over the phone without the patient having to go anywhere or have someone respond to their location. Of the remainder, less than 3% result in a call rolling over to 911. For those who need and are agreeable to an in-person response as a result of contacting us, we can dispatch the CMT program that Erica mentioned earlier. Funded by Adam and available 7 days a week, timed to peak call volume, this almost 8-month-old program sends either a pair of licensed clinicians or a licensed clinician and a peer to where the patient is, rather than assuming the patient needs to get to us. Not only are the staff at North Central Mental Health also able to dispatch CMT, but as Erica mentioned, the relevant agencies have started the discussion of 911 and 988 interoperability to make sure that the right caller gets the right service at the right time. CMT can both transport appropriate patients in their unmarked cars, which obviates the need for a police or ambulance run, or continue to follow up with that patient in the community for up to 14 days after the initial encounter. The gist is, we know most crises don't go away in a minute. Most people need some follow-up to make sure that they continue to do well. We are excited that in the coming year, and with funding that Adam applied for and won, we anticipate being able to expand this program. For those who do need building-based care, and let's be honest, a good share of our community does need that, we also offer multiple levels of what is referred to as the least restrictive level of care. Since we started deinstitutionalizing people 60 years ago, the mantra has been, correctly, that people should be served in the least restrictive environment that meets their needs. Our crisis stabilization unit accepts referrals from CMT and Franklin County emergency departments. With lengths of stay of up to 7 days, this program is an alternative to locked unit hospitalization for patients appropriate to that level of care. We place a strong emphasis on warm linkage to aftercare services for these patients, such that things don't fall apart on discharge. Our data here, while somewhat incomplete, is also good. With the data that we're privy to, we believe that less than 10% return to a crisis provider of any kind within 60 days of discharge. For reference, that's well below what's quoted in the medical literature. Similar thinking and data apply to our Miles House program, which is targeted more towards CSU discharges and inpatient psych unit discharges. Last but certainly not least, I am glad to see and to hear from Oyama Garrison here today, as our two agencies work together on still another alternative crisis response. Our reach out workers, or the ROW team, picks up those who are intoxicated in a public space and delivers them to a place of safety, namely Mirror Haven's Engagement Center, where they can sober up and hopefully come to engage in substance use treatment. This partnership has existed for decades, and in that time has probably averted hundreds of thousands of ED visits and first responder runs. In conclusion, we at NetCare are truly happy to see the idea of alternative crisis responses take root. Indeed, we've been working with patients from that frame of reference for some time and look forward to continuing to do so with so many more people on board. Thank you for your time, and I'm happy to answer any questions.
Thank you, Chair. So Dr. Lowe, you are piloting a non-police response.
Correct.
How's it going? You hit on it very lightly, but how is it going? What are you learning? What can we take? You've been doing it for 8 months. What can the city learn from what you are learning about a non-police response?
Sure. We are up to about 80 patients per month now. So you get a slow start at first while people get used to that program and get used to summoning it. And we're currently seeing about 80 a month. We are not running 24/7. It's been mentioned that staffing is a real challenge in these professions. And quite frankly, you run into staff who don't want to work weekends, understandable enough. And you get staff who say, I'm really worried about being out in the community in the dark at night. And so we have kept this to 10 a to 10 p 6 days a week, and on Sundays it's noon to 10. What we're finding is that our call lines who field these calls need to do a really good job of screening patients. And I'm not saying screen folks out, it's more like screen folks in. We need to make sure our staff are going to be safe when they get there. We need to make sure that our staff are able to be effective when they get there. And we need to make sure that that patient is agreeable to us coming. We will not send a civilian team to a patient who's not interested in seeing us. So we really want to make sure this is the right program for them. That said, when we look at demand as compared to what the program serves, they're very closely aligned. It's finally starting to outpace. And that's why we're really happy that we were at the precipice of expanding it. But so far, it shows really, really promising results. A good number of people are staying in the community. A good number of people get follow-up and get linkage as a result of having seen this team. And the idea is to get them linked to services such that they don't need to fall into crisis again.
Can you give me the profile of a typical this client?
Sure. This program serves 18 plus. There is a divide with youth, but at the end of the day, it's 18 plus, feet in Franklin County, not necessarily a Franklin County resident. And generally speaking, it stays within 18 to 65. We do have some exceptions at the older end of the range, but generally speaking, it's in that core pocket. Most folks that this program sees have a diagnosable mental illness. Not everybody does, but most have a diagnosable mental illness, and up to 85% have comorbid substance use.
Thank you.
Thank you very much. Appreciate the opportunity to hear from you this evening. Next, we have, last but certainly not least, Ayoma Garrison from Maryhaven, CEO of Maryhaven. Welcome.
Right. Good evening, Council President Hardin and Chairman Remy. I have the honor and distinct pleasure of serving as the President and CEO for Maryhaven. And let me just share with you that alternative crisis response is working. And when I tell you that it's working, it's because I hear it firsthand, because we are Central Ohio and one of Ohio's largest and oldest and most comprehensive evidence-based behavioral health care providers, which means we see the clients, we see the community, we see the people, and we hear their responses. And I am proud to share, when we hear responses from them, they tell us, first responders, the NetCare Roll team, the RREACT team, so many others provide them with a sense of decency, dignity, and respect. And I will tell you, on that continuum of care, that sets us up for success. Because that means when they are responding in a proper form and fashion and providing professionalism to those who are suffering, whether it's from mental health crisis or from substance use disorder crisis, when by the time they reach us at our Maryhaven Addiction Stabilization Center, we are better equipped, we are better set up for success to be able to respond with proper levels of care and treatment for the clients that we see every single day, 24/7. And I am proud of the staff at Maryhaven and all the other workers within this industry that deliver compassionate care every single day. And when it comes to alternative crisis, it's so important because there's a measure that we often tend to forget. We live by this rule, 6 degrees of separation, and I'm here to tell you tonight that the data will tell you it is actually less than 1. In every family, you are going to find some level of mental health challenges or struggles. You're going to find some level of substance use disorder. Every single family. And they all deserve respect and dignity when they have a moment of collapse. And that is what our first responders have been doing. That is what the great work of so many other community partners have been doing, is providing them with that level of dignity and respect. And when they come to Maryhaven, let me tell you, we have seen the numbers increase. We have seen it because they're also beating the stigma. When they come to the Addiction Stabilization Center, historically, we have seen somewhere around 70% of those clients dealing with some level of substance use disorder, and the remaining alcohol. We've now seen that for alcohol triple. because of what so many people have experienced over the last 3 years. So we're grateful for how these programs are providing a sense of dignity and care. When they do come to us, even at the Maryhaven Engagement Center, when NetCare program, when that program drops individuals off at our center, these are generally the unhoused who are heavily intoxicated. And some may be dealing with a little bit of what we call comorbidity, which is a mental health challenge or crisis. When they drop them off to our facility, we have an opportunity to get them back on the proper path. And thanks to the partnership with Adam H. and with CSB, the Community Shelter Board, and in this community collaborative work with not only the first responders, but also with NetCare, we have seen somewhere in the neighborhood of about 40 to 50% of the individuals that get dropped off at our engagement center who are unhoused decide to seek treatment long-term and decide to go into permanent supportive housing measures. That means an opportunity to get them off the street and get them back onto a path of success as good contributing members of society. So I'm here to tell you, as a provider, as someone who sees the community, someone who interacts daily with our first responders, with RREACT, with NetCare, and so many others, when it comes to alternative crisis response, again, it is working, and we're grateful. Thank you. Any questions?
Thank you very much. Council President, do you have any? All right, thank you very much for the testimony this evening. We appreciate all of our partners stepping up to share the collaborative work and the work that they're doing individually. Let's move on to our public speaker portion of the hearing. We have 7 public speakers this evening and received 6 pieces of written testimony, which we passed along to our colleagues. First up to speak is Helen Ann Sweeney. Ms. Sweeney, if you will come up, state your name, address, and any organization you may represent. You have 3 minutes to speak.
Good evening, President Hardin and Councilmember Remy. My name is Helen Ann Sweeney, representing Brad. I live at 254 West Schreier Place in Columbus. Over the past 5 years, Brad and other community stakeholders, such as the Columbus Public Safety Collective, have advocated for an alternative police crisis response system. We support this system because our community has overburdened police officers with responsibilities that they are ill-equipped to handle. They have received minimal training on how to deal with those having a behavioral health event and cannot provide the necessary follow-up services. This initiative would release police of having to respond to crisis situations that are beyond their ability. Brad advocates for a comprehensive system to handle a wide range of issues, including behavioral health, traffic accidents, and neighborhood disputes. Social workers, peer supporters, and other community workers, rather than police, would respond to 911 alternative calls. Workers would offer referral and follow-up services to ensure that residents are connected to appropriate resources. This connection should increase the likelihood of positive outcomes. Further, the system would build trust between the city and the community and reduce police hours that in turn could be used to deal with increasing violence and crime. In order to develop this alternative system, the city needs to take 3 steps immediately. First, it should spend a portion of the $1.2 million allocation to hire a consultant by the end of this year. Second, the consultant should work with the community to establish a community oversight board by March 24. This board should be involved in all aspects of planning and implementation. Finally, the 911 call center should be overhauled to make it a key component of the crisis care continuum. As part of this overhaul, new protocols should be implemented to route calls to the appropriate responders. Other cities, such as Cincinnati, have dedicated resources and solicited citizen input to develop pilot programs that have demonstrable results. In response to President Hardin's question earlier this evening, Cincinnati has successfully linked its 911 and 988 call centers. We think that the city officials here in Columbus should learn more about how these programs are configured. 5 years have lapsed since BRED and other community groups have requested an alternative police crisis system that meets Columbus's residents' needs. It is time for the mayor and city council to make a commitment to adopt and implement this system. This commitment should include adequate ongoing funding as well as a resolve to solicit input from the community. This system will be a major step in restoring the trust between the city and the community. Thank you for letting me speak tonight.
Thank you very much, Ms. Sweeney. Next is Reverend Shea. Looks like Reverend Shea is not here this evening, so Stephen David is up next, and then Chana Wiley right after. Welcome back to council. Please state your name and any organization you represent.
Thank you, Chair Remy, President Hardin, for the opportunity to testify today. My name is Stephen David. I'm a social worker living at 166 East Welch Avenue in Marion Village, and I'm a member of the Columbus Safety Collective. So I must admit, this has been a bit of a frustrating evening for me. As 8 months ago, Council included funding in the 2023 operating budget to establish a non-police emergency response program in our city. Yet we've seen no visible progress on this specific programming that the community has been asking for over the course of the past 2 years. In reality, our city is falling farther behind other cities, and we're making national headlines for the wrong reasons once again, such as when police are showing up to non-emergency calls to tell a parent that they will charge his 11-year-old daughter with a crime. So since our last time here at Council, members of the Safety Collective have been talking to administrators of non-police response programs in cities here in Ohio and around the country. And one of the things that I'm most struck by when talking to people in these other cities is that when there is political will, it happens. In Cincinnati, in Dayton, in St. Petersburg, Florida, despite the complexities of city government structures and call systems and existing programs, the work begins when there is a commitment to make it happen. After their own 2020 listening sessions in St. Petersburg, city leaders got to work and they built a program by January of 21. President Hardin mentioned our listening sessions that we did on a similar timeline, and we have yet to see the progress here. So I hope you understand the frustration that we have seen as we've heard our community advocate again and again for these non-police teams to be built and staffed by the city, and we want to see that happen now. And we've seen today that the health and human service community is stepping into this gap in leadership with their own services. But this fragmentation makes it hard for residents to know that when they need help at their door without police involved, that they don't need to know a separate agency or separate phone number to call to make those connections. So while the initial steps in this journey have been slow and frustrating for us, the opportunity of this moment is not lost. Without structural reforms, our public safety system will remain mired in this crisis of legitimacy. But building a new health-focused response structure for our city, we can build in community ownership through direct oversight and targeted incentive-based recruitment to lift up our neighbors to do the work in ways that only those who love their communities can do. We've heard so much about staffing. We have ways that we can deal with this by finding the people already doing this work in our communities and bringing them into a new call to service. We can also design rigorous evaluation to say with confidence the impacts of these programs. Beyond anecdotal evidence and descriptive statistics about numbers of calls answered, we can do good science around these programs if we invest in it at the front end. We have brought you a plan and pillars to guide how to do public safety in an anti-racist and health-centered way, but we need you to act. Non-police teams are both a harm reduction mechanism for our neighbors most at risk of harm from interactions with police, as well as an opportunity to rebuild our public safety system to lift up the expertise of our neighbors, make decisions based on evidence, and is accountable to the community. We are asking Council to use the funds allocated to hire staff to begin this work and ask department leadership to come to the table to plan these programs. Thank you so much for your time. Happy to answer any questions.
Thank you, Mr. David. We appreciate your testimony this evening. Chana Wiley?
Actually, Chair.
Oh, go ahead, sorry. Council President.
I know we're getting to the 2-hour mark already of the hearing, but I've said this before Ms. David, that there are a few outside of the city that I respect in terms of your advocacy for this in this space. I think that your knowledge and your research is real, and so I appreciate the advocacy. I think we have shared goals in creating this other alternative. That being said, and so we work with you to get the $1.2 million set aside, and we acknowledge that we have work to do there to move that forward. Would be interested in your opinions, though, of the NetCare alternative crisis that is operating right now, a pilot, and how that should instruct how the city should move forward with a pilot. Is there not data, as Ms. Anita said, and as Dr. Lowe said, that is there not value in evaluating, watching the NetCare model?
Yeah. President Hardin, there is certainly value in the programs that we've heard today. Deeply grateful for the work that the folks in NetCare are doing. In the listening that we have done through our community conversations and engaging with our neighbors, there are key pieces of how we want to see this program built that are not currently addressed by any of these pieces in the structure. So you mentioned your opening comments, like this need for an advisory board. The way that we're thinking about this is through civilian control, or like the people of our city should control what these programs look like. We know there is this crisis of legitimacy with law enforcement because there is no accountability that happens when a wrong happens. We need to know that our neighbors have control over these programs and what they look like. Many of these other programs that we've heard about, we've heard so much about staffing of social workers. The way that we are talking about this work and what we've seen other cities do, like the folks out in the macro program in Oakland, are not looking to the licensed mental health community. We know that there are racist pipeline barriers to become a social worker. There are serious issues getting through it to get those kind of credentials. Our community members can do this work. They are doing it every day. They are diffusing conflicts in our neighborhood. They are the most culturally fluent ones interacting with our neighbors. We need to be thinking about ways to lift those folks up. When I hear about this money that is being spent for a communications campaign starting in '24, that's the kind of investment the city needs to make, but we need to make it with the right pieces in place. The piece of having civilian-controlled, non-police response is really critical to how this looks. And I fear that if we start going down this path of trying to sell this to the city without having make these structural reforms for folks, that we're going to lose people at this critical moment to show them that you can trust this new system we put in place because we're doing it in a different way and showing a new kind of service to our community.
Thanks
Thank you so
again.
much.
Appreciate you. And we have Chana Wiley. Ms. Chana Wiley, please state your name and the organization you represent, and you have 3 minutes. Welcome back to Council.
Hi, I'm Chana Wiley. I'm with Columbus Safety Collective. Council President Hardin and Chair Remy, thank you for the opportunity to speak this evening. Again, I'm Chana Wiley, the sister of Jerron Thomas. It's very important to tell his story again and again at these hearings. In January of 2017, Jerron called for help while in a mental health crisis. When officers arrived, he was beaten until he coded and later died in the hospital several days later. Last week, my son, who is 21 years old and suffers from mental health, was also in a crisis. He was at the Star House, and he was upset that they wouldn't let him in. So he decided to throw rocks at the building. There was no damage to the structure of the building. He was throwing rocks. So they called the police on him. He walked away and headed towards Fifth Avenue, and he was approaching the Burger King parking lot and saw lots of cruisers pulling up, and he got scared. We're still traumatized by my brother, his uncle's passing. And he asked, am I gonna get arrested? And they said, maybe. So he took off running because he was scared, and he ran into the Burger King. Once in the Burger King, they detained him, threw him to the ground, had him by his locks, had his head into the floor, and handcuffed him. After they handcuffed him, they punched him in his face, and they kneed him in his face. So he has scars all over his face, and his skin on his arms is off. This is just a living example of why I'm an advocate for a non-police response system to mental health calls. It has hit my home twice, and I just don't know what it would take. I don't know how many more residents need to be harmed, but it doesn't happen everywhere. It happens in underdeserving communities, mainly Black and brown people. So we know that the police are equipped and trained well to de-escalate. We just would like to do it a different way and be more innovative with the way Columbus Safety Collective has come up with policy pillars and strategies on how to do this work and uplift community members to do the work they're already doing, like Stephen mentioned. We know those funds were allocated, and we're just asking you to please give us a try and implement this program. Thank you.
Thank you very much, Ms. Wiley. We appreciate your testimony. Want to mention that Pastor Jed Deering had to leave early. Next up is Elena Privatera. Welcome to council. Please state your name and any organization you may represent.
Hi, my name is Elena Privatera. Yeah, it's okay. I am representing myself as a Columbus resident. Thank you, Councilmember Remy, for having me here today, and I know Councilmember Hardin was here earlier. I am a medical student and a Columbus resident, and I'm in my clinical rotations right now, and so I'm seeing a lot of the challenges that my community members are facing, especially related to homelessness, substance use, and mental health disorders, along with myriads of other problems that people just tell you about when they're in the hospital. And I'm learning that it takes no shortage of skill, patience, teamwork, and resources to appropriately respond to someone that's in a crisis, and in the aftermath of those crises as well. It takes years and months of time to take care of people. I think it would be unreasonable, and I think many people here would agree, as they have been working on adapting our crisis response programs, to expect that a police response alone is adequate for these crises. And I think that, we have, in 2020, City Council had the Reimagining Public Safety Initiative with an overwhelming majority of Columbus residents saying that they were very or somewhat comfortable with alternate teams responding to a range of 911 calls. And our responders who testified earlier here today have also demonstrated that they're working to adapt our crisis response to make it more appropriate. I think that it's, as a person who lives here and is like, where do I call when I'm in need? Do I need to call a different number if I'm 18 versus 21? That's very confusing if I want to reach Nationwide Children's. Or we talked a lot about substance use disorders and mental health, which is pertinent in this city and pertinent across Ohio. But there's also other crises that are not mental health related, like what do I do when I'm stuck on the side of the highway? Things like that maybe don't require a police officer's response, especially given how dangerous it can be to have interactions with the police in this city, which is what's really concerning to me is in terms of public safety and someone who wants to promote public safety through public health, I don't want my neighbors to be afraid of the institutions that are supposed to be there to support them. So I full-heartedly support efforts to make an alternative crisis response, and I don't think it could be more urgent that City Council does this and does it in a way that's unified and also has civilian oversight like the Columbus Safety Collective has said. And they also have created a whole blueprint that Council could go through to implement this, and then also following the examples of my hometown, Cincinnati, or Dayton, or and efforts that are underway in Cleveland as well. So I think there's a lot of opportunities, and I'm really hopeful, but I think this is really urgent and needs to be done as soon as possible. Thank you.
Thank you very much for coming down this evening. We appreciate you. And then last but not least, we have Molly Shea on WebEx this evening.
Hi, should I go ahead? Can you hear me?
Yes, we can.
Okay, great. Thank you so much. Yeah, my name is Molly Shea. I am a community member here in Columbus. I also do some work with the Columbus Safety Initiative. My address is 1047 Mohican Avenue. And yeah, I just want to thank you for creating some space to hear from community members today during this hearing. I've lived here in Columbus for a vast majority of my adult life, and it was really in moving here that it became very self-evident of the issues of policing and racism that we have in this city. Really became clear, honestly, the first day, just like seeing how the city functions. We've built a reputation of being unsafe, and the police have proven themselves to be untrustworthy. Yes, they are untrustworthy when they murder people, but also in the smaller interactions, like some of them that we heard tonight even. This past summer, I actually found myself in something adjacent to a domestic dispute with a former partner, and I did not feel safe at home, but I also knew I could not call the police. I had family members telling me that that was the best choice and that that was the way I could keep myself safe. But I was confident based on what I have seen proven by the Columbus Police Department that that would not be the choice that would help de-escalate or keep me safe. And it would certainly not have kept the other person involved, who was Black. I am white. I realize you can't see me on screen, but I am white. Would not have kept her safe either. And so I never had the option to call for help outside of my community. I didn't have any institutional support in that moment when I desperately needed it, because the police have not been a safe venue for people here in this city. So we desperately need a non-police emergency response. So I could have called, so other people could call. As has been stated by various folks tonight, there's some specific markers that we can really be reaching towards, some specific instances that we can, move us to get us there. But that is urgent. We cannot continue to wait on it. Emergencies happen all over the place, and our communities need help in those times, and they need help by trained professionals they can trust. Our city has promised the money to start this, and it's past time we start to see the real progress. So I'm just here to ask that we start moving forward and start taking action quickly and cut the delays and really move to a place of having a non-police emergency response in our city. And that's all that I have.
Thank you very much, Ms. Shea. We appreciate your testimony this evening. Are there any final comments for the record from Director Prashadi or anybody else from the department? Everybody's good? Okay. Well, we certainly appreciate the testimony from not only the presenters, but our public comments as well. We believe this was a robust presentation, and certainly the conversation about Columbus alternative crisis response, it does continue. It's my objective, and I think that I speak on behalf of my colleagues, that we are working towards the opportunity to answer every single call that comes into the city of Columbus with the right response every single time. So although we're using it for one particular program, it doesn't change the fact that that should be the overall objective. And we are certainly working towards that. And this is just one piece of reporting out and finding intentions for the future. And certainly this council will be very supportive of continuing to support the department as we traverse this road ahead. Next week, we will host a second Public Safety Committee hearing, this time over violence prevention and reduction programs. We look forward to reconvening for that important discussion on Tuesday, October 10th at 4 p.m. here in Council Chambers. Those who would like to provide written or spoken testimony can sign up with my legislative assistant, Kaylin Pittman, at cdpittman@columbus.gov. Again, that's cdpittman with 2 T's at columbus.gov by noon on the 10th. Thank you to our directors, department representatives, and presenters. As the chair of the Public Safety Committee, I'm extremely proud of the work that has been done so far and excited for the work and the growth to come. Thank you to Council President Hardin for being my co-host this evening for these important public safety hearings. In addition, I truly appreciate Mayor Ginther's attendance and remarks at the beginning of this hearing. This partnership is critical. Thank you to the council team members who made today's hearing possible. My team, Lucy Frank and Kaylin Pittman. Council President Hardin's team, John Tanous, Linda Copobianco, Mike Brown, Senior Legislative Analyst John Oswald, our communications team, Mark Carter, and the entire CTV team for their assistance in preparing for this hearing. And last but not least, thank you to the residents and stakeholders who attended and participated today. I hope you all stay safe and have a great evening. This concludes today's hearing, and I hope to see you on the 10th next week.